I'm Bob Bonow at Northwestern University and Northwestern Memorial Hospital in Chicago, and I'm delighted that the American College of Cardiology, American Heart Association guidelines on management of valvular heart disease is being released now in 2014 after several years of deliberation and revision from the previous guidelines. The last guidelines were actually written in 2006, so it's been 8 years, and even though there was an update in 2008, very little happened between 2006 and 2008 in those guidelines, but a lot has happened in valvular heart disease over the last 6 to 8 years, and it's good that we're now getting this revision out to the practicing community to help us manage all of our patients with valve disease. A couple of really important updates here. First of all, these guidelines were chaired by Rigna Shimura at the Mayo Clinic and Catherine Otto at the University of Washington. And Drs. Nishimura and Otto did a great job of rounding up those of us on the committee and getting our thoughts together. One thing which is brand new is to look at valve disease the way we look at heart failure at various stages of progression of disease, of severity of disease, so that we have stage A, which is when people are at risk of developing valve disease. For example, someone with a bicuspid aortic valve or mitral valve prolapse without regurgitation. Stage B is when patients are already have disease, but they're asymptomatic and it's mild. C is when patients have severe disease but are asymptomatic, and then D is when patients have symptomatic severe disease. Very much the way we look at heart failure. Once we categorize patients that way, then it's much easier to talk about how we're managing those patients differently according to the guidelines-based approach, based upon those various stages. So that's one way which we're now beginning to look at things, which is really brand new and probably quite important as we go forward. The other thing we're bringing into the guidelines now are the transcatheter valve procedures for treating patients with aortic stenosis or mitral regurgitation. And in fact, that's why the timing is what it is, because we couldn't write those guidelines until we had approved devices in the United States. That's why the European guidelines came out 2 years ahead of ours, because they already had those devices approved. With these approved devices now, we have recommendations for the use of transcatheter aortic valve replacement and also for the use of the mitral clip for treating patients with very symptomatic but high-risk mitral valve regurgitation as well. So that's also now embedded in our guidelines for the first time. We've streamlined some of the recommendations for how to treat patients and when to treat patients with aortic stenosis, with particular emphasis now on looking at patients who may be asymptomatic with severe aortic stenosis and moving more towards surgery and not waiting for symptoms when the aortic valve is severely stenotic, as well as patients with mitral regurgitation. When there's severe regurgitation, we still have a 2A indication for considering surgery in patients who have repairable mitral valves, if we can send them to a surgical center where there's great experience. But now, instead of saying there should be a 90% or greater likelihood that the valve will get repaired instead of replaced, we're saying it should be 95%. So we really want to make sure patients are going to an experienced center. And that's the other part of the guidelines, which I think are worth emphasizing. We and others are really emphasizing the heart team approach. Patients should be referred to centers where there's expertise in diagnosis and treatment. And that means a center where there's cardiologists and cardiac surgeons and nurses, and many other times anesthesiologists who are developing a heart care center of excellence to really manage our patients in the most expeditious and optimal way. And that's what I think built into the guidelines from stem to stern. So we're looking forward to seeing how these guidelines play out in the community. I think that the practicing physicians and nurses will see that there's much more substance here than previously, and let's hope that this also leads to improved patient care.